now to have further discussion of the evidence and take a series of votes. And again, we have our patient experts available to us. Julia and Katie, we have Dr. Simon. I just want to make sure. Nope, not yet. And I don't think we have. There he is. Fantastic. Hi, Mark. Thank you. And I don't believe that Dr. Levine has been able to join us yet, so we'll hopefully still get her for the policy roundtable. But why don't we go ahead and launch into discussion of the voting questions. It's relatively kind of streamlined since there's just this one drug, but it will give us more time, in a sense, to revisit some of the issues that came up this morning. So to be clear and to frame this, the first vote, which will be on comparative clinical effectiveness, the patient population is adults with World Health Organization functional class 2 and 3 with pulmonary hypertension who are on background therapy. That basically reflects the patients who are in the trial. That's not a guarantee that that will be what the FDA label says, and we will talk about that in the policy roundtable. But this, for your kind of framing of your thinking about the evidence in these votes, that's who we're talking about now. And the first voting question, if you can go to the next slide, is this: is the evidence adequate to demonstrate that the net health benefit of sotatercept added to background therapy is superior to that provided by background therapy alone? And let me invite Grace, if she would please, just to briefly, very briefly, refresh your memory of the key findings of the evidence, referring to our evidence summary of tables from the main report and the rationale behind the ICER evidence rating. Grace?
Thank you, Steve. So I will direct you to tables 4, 5, and 6 of the evidence summary for key trial results, which include the primary outcome 6-minute walk distance. And in the sotatercept group, there was a 40-meter increase in the 6-minute walk distance on a median change from baseline. Sotatercept also improved WHO functional class, and then a host of hemodynamic and biomarker parameters like pulmonary vascular resistance. And also patients had improvement in multi-component endpoints, which included in table 5, you will see time to first occurrence or death or non-fatal clinical worsening, which are mainly initiation of rescue therapy or an increase of dose in prostacyclin by 10% or worsening of PAH. Table 6 is the harms, and in general, sotatercept was very well tolerated with few serious harms, and in fact had lower rates of adverse events than placebo in many cases. And so this led us to an ICER evidence rating of B+.
All right. And again, B+, especially for those who aren't as fluent in our lingo, our jargon, that's high confidence that it's at least a little bit better than just background care, but with uncertainty around the magnitude of that benefit, ranging from a small-ish incremental benefit up to a very substantial benefit. Okay, let me turn it over to the CEPAC then. You had some excellent questions and comments immediately after Grace presented it this morning. Would any of you like to follow up on any of those questions or comments, restate them? At some point, I'll probably ask for some opinions around why you think you're going to vote yes or no on this question. But anybody would like to start off, please raise your hand. We did have a good discussion. Greg, do you mind if I invite you? Did you want to say anything more about your sense of things after you made your comment? And there was some further comment about the issue of median results and clinical significance. Anything else you wanted to describe your own thinking as it's evolved on that point?
Well, no, I think I just wanted to make the point that, when you're dealing with a median like that, you're dealing with half and half. And since the point estimate was sort of right at the minimal clinically important difference, you know, it's pretty clear that half the patients probably didn't hit that minimum clinically important difference. The other point that I would want to raise, though, and see what others think about this, I'm still kind of uncertain about the terminology of disease modifying. You know, it's easy to say that. It's a lot harder to document that. And I'm still wondering in my mind the extent to which the disease modifying issue here is more aspirational at this point than really documented. But maybe others have seen other evidence that I haven't seen. So I'd be interested in comments.
That's an interesting point. Now, I want to invite Dr. Simon to comment on that, and because in my own experience, people really do have different takes on what it means to be disease modifying. It may depend on what the disease is, but that is a loaded term sometimes. So, Mark, with your experience, not just the sotatercept, but other drugs in this area, what's your understanding of that term? And I guess, what would your view be of whether the evidence suggests a disease modifying effect or not?
Yeah, great question. So when I think about disease modifying in pulmonary arterial hypertension, what I'm thinking about is remodeling of the pulmonary vasculature. So, or I should say reverse remodeling. So in pulmonary arterial hypertension, there is remodeling and essentially thickening of all layers of the pulmonary vasculature, endothelium, smooth muscle cell layer, et cetera. This results in, as you can imagine, significantly thicker and therefore stiffer vessels that affects what we measure as resistance to flow, which more broadly speaking is probably impedance to flow, and therefore a load on the right ventricle ultimately, which is the mode of death really for most patients, is right heart failure. So when I think about disease modifying, I think of some effect on the vasculature to reverse that process of remodeling the vessels in this way. There's generally been a fair bit of preclinical literature among different treatments for this. It's very, very, very difficult to prove in clinical research. In the PAH field, I will say to some extent we aspire to be like the oncology field in terms of some of this, but really we don't have access to tissue to prove it one way or another. We're not going to do lung biopsies on our very ill patients. So from a clinical perspective, a lot of times we rely on the very few trials that are postmortem sometimes to document some of this. So very hard to get at. There are some technologies that perhaps will continue to develop to allow us to image the pulmonary vasculature in such a way to get some of this data, but we don't have that available to us, broadly speaking, now. So with that in mind, I think it's very, very difficult to prove clinically this point of disease modifying. The data that we have shows that there's improvement in pulmonary vascular resistance and pulmonary pressures. Cardiac output stays about the same. A lot of this sort of physiologic data to us suggests that that this effect perhaps is modifying vascular remodeling. But in the end, we don't know. And I guess as I've been thinking about this question more, because this is a big question for this drug, considering that all of our other approved therapies are pretty well documented vasodilators. That I guess I take a step back from this question a little bit, and because it's going to be very hard to answer, and I rely on the clinical data that we have available, which is that essentially patients are able to do more, feel better, and have other markers of better outcome, albeit not enough data to say mortality per se. So I've been thinking about it as, yes, I would love to be able to say this, but how important is it to me to say that with the other data that we have available, and quite frankly, the other data we have available for the other drugs, for that matter, it's in line with. So.
Great, thank you. I think that's really helpful for everybody. All right, we have 3 hands. Let's run through them. Bijan, go ahead.
Yeah, I'm looking at the table 1, which is basically describing the cohort, the 2 cohorts in the 2 arms. So I guess my question is how, remember we are talking about the population that we should be looking at in terms of the drug's impact. And if I look at the subgroups, so there, in table 1, actually 3.1, there is sort of, it seems to me it's significantly different. The significant difference in the number of or proportion of patients in idiopathic group. So it's 51 versus 66. And I guess the question is, in terms of impact, should we be looking at that specific subgroup too? And this is the other reason I have is, if you go to I went to the NEJM paper, and in there, I think in the supplementary table 4, they have a tornado diagram. And you can see that the impact is very significant only for that group, but for the other 4 groups, subgroups, it is not as, it is basically in borderline. I guess my question, what's the impact?
Why don't I let the research team comment on that? Grace?
Yes, thank you. So you're correct in that in one of the things that was pointed out to us by clinical experts as well, is that there is some important subpopulations like the connective tissue disease associated and the drug and toxin induced PH patients who are underrepresented in this trial. I think there's not enough data from the subgroups to know whether there's a significant difference between etiologies of how this drug works. I think that remains one of the uncertainties of whether in populations where historically they haven't done as well with the existing PH medications, whether sotatercept had, what effect sotatercept has. So that played into our uncertainty, and the B+ rating is that there may be subgroups for which we may have a different effect, and we just don't know. We don't have enough data. Mark, do you have any other comments to add?
I'll just say that in terms of drug and toxin, it seems to be underrepresented in most of our clinical trials compared to our other subgroups. So to me, this is in line with our other large clinical trials. The difference in idiopathic PAH is well noted. I think some of that is varying degrees of diagnosis of heritable, which a lot of times, if you don't find the gene, gets lumped in as idiopathic. My guess is it wouldn't explain all of that potential difference. The biggest observation, and this has been raised, is there seems to be a relatively under enrollment of patients with connective tissue disease. I don't know exactly why that is, and certainly as a clinician, I would like to see more information on that as well, and further data on that subgroup.
Just a brief comment about it's not gamesmanship. It's just the way that things would usually work at FDA. For a drug like this that has no strong safety signals, they're very unlikely to go into the data to try to create subpopulations for which they would approve it and others for which they wouldn't, unless they had some really dramatically different signal on effectiveness. But given the numbers, I can't see that happening. So the question, Bijan, we'll still ask you to view this population as a whole with the data that we have. But again, the median results, all that is based on that larger kind of population anyway. Stacy?
Thanks. So I know that the trial focused on people who were on stable background therapy, but one of the comments from one of our public commenters and patients was around having run out of treatment options. And so I guess I was just wondering if our clinical experts would be able to say anything related to their thoughts about this treatment outside of the type of trial population we saw on stable therapy. Are, is it likely to be really beneficial or even maybe more beneficial for someone who the other drugs aren't working anymore?
I want to suggest a short answer to this question because I want to talk about that in the policy roundtable too. It'll be a big issue around use outside a label or what the clinical criteria are for it. But Mark, why don't you go ahead? It's a great question. Why don't you go ahead and address it?
Yeah, a quick observation that I have from the Stellar trial was that about 60% of patients were on triple therapy. So you could argue, right, how stable were these? It's a little hard to, I think, particularly from a clinical trial perspective, to define, these, as we've heard from our wonderful patient advocates here, this concept that the drugs aren't working. So you do have to be somewhat stable, but what does that really mean for enrolling a trial like this? With 60% on triple therapy, you have to expect that, in my mind, that covers perhaps to some extent that patient population where these drugs aren't working or clinician is seeking or patient is seeking additional therapy.
Thanks. Reem.
I kind of wanted to just highlight a point that, Mark mentioned earlier. I am not as bothered actually by the fact if we know or don't know if it's a disease modifying, because even if we had data for something to be disease modifying and it doesn't help patients, I don't want to use it. I think the one point that I asked about it is that there wasn't an improvement in quality of life. But even with that, I'm just putting my kind of methods hat on. Unfortunately, a lot of our quality of life current tools are not good in showing us a longitudinal over time effect in relation to improvement or progression. They weren't actually designed for that, and they don't have enough discrimination within them. So I'm reminded of that. I'm taking all what we heard, the positive results, but also what we heard from the patients. The last thing I'm going to say is I would really be very keen in future follow-up that there is some sort of a composite outcome that combines mortality and need for lung transplant. Because to me, that's such an important, solid outcome that will show us if these medications, how big of an effect they're having on people important outcomes. But overall, I think in light of very minimal harm based on what we heard and improvement in multiple outcomes, some of which are patient important, I'm kind of viewing this as a pretty good treatment. I also would say that we haven't had many B+ in a while, so it was nice to see that rating.
Great, thank you. Why don't we go ahead and put the voting question up again, and let's let the CEPAC vote. Do we have 13 voting members? Staff, can you confirm for me? I think that was anticipated. There was one member who was, I think we've got all 13. Please just let me know if that's not the right number. Okay, let's show the results. 13 yes and 0 no. All right. Unanimity happens rarely on the CEPAC, but when it does, it sends a strong signal. So the next portion of votes address, if you remember my description of the value framework, we're going to be talking about those contextual considerations and potential other benefits, or sometimes we call them benefits beyond health. And so let me just go ahead and show the first question. And it's framed this way: when making judgments of overall long-term value for money, what's the relative priority that should be given to any effective treatment for pulmonary hypertension on the basis of the following contextual considerations? I know that's a very long intro, but what it means in specific is that we're not here really talking about whether sotatercept works fantastically or a little bit. We're really talking about the unmet need for patients in the current treatment landscape without sotatercept. What is their relatives? What's the severity or unmet need of their condition? And we ask that in two different ways. So if you can show the first voting question, the first is, what relative priority would we give to any effective treatment for pulmonary hypertension based on the acuity of the need of individual patients, based on their short-term risk of death or progression to permanent disability? So this is largely meant to capture that perspective of severity in which patients might have, again, a very high short-term risk of progressing to death or permanent disability. Sometimes a little bit hard to figure out whether conditions are like that or not, because patients are always on a spectrum to a certain extent. But Mark, maybe I can ask you again, as a clinical expert, when you view the idea, when you see a patient with pulmonary hypertension, what's your view of their short-term risk of death or progression to a more permanent disability?
Yeah, I think we've heard pretty well how devastating this disease can be. This is something that as clinicians we take very seriously when patients are coming to see us, particularly the first time, and we're evaluating them, particularly in the context, as we've heard, of delay in diagnosis, which we know also has impact on outcomes. Acuity is very important. I think we have known historically that this disease is very deadly. Our treatments have improved this, and to a pretty good extent, but within limits. And so I think from that perspective, as a clinician, we absolutely still need better therapies, newer therapies for this disease.
Can I ask you now, in terms of the spectrum of disease, we may not even really know the epidemiology that well. How many patients are sitting out there with, functional class 1? My assumption is that by the time they get to you, they're 2 or more likely even 3. So, I mean, how many patients are out there with pulmonary hypertension in the kind of, I would say, less severe category? Do you have any sense for that?
I think that's a very hard number to come by. Absolutely, when patients present to us, I would even venture to say they're more likely functional class 3 or 4, although there's definitely a wide range. It's very hard to say with, how many are really just functional class 1. That's, from a clinical experience perspective, it's pretty rare to get a patient referred that is that functionally well. Every so often we'll see it, but I would say it's rare.
Okay, good. Katie, I was going to ask patient experts if they had a comment anyway, so thank you. Go ahead.
Thanks so much. Yeah, I just wanted to sort of add to Dr. Simon's perspective. I think one of the data points that PHA draws on sometimes when we're talking about disease severity is from research from a few years ago that indicated that because of the delay in diagnosis that we've discussed, that about 75% of patients are in an advanced stage of the disease, so class 3 or class 4, by the time that they do actually take up adequate therapy. And I guess I don't have a strong statistic to tie to this, but just anecdotally, I would say that there's a significant portion of the community that do either go on to disability or have a major life transition that involves losing their career, losing their ability to work in one way or another. I would estimate more than 50%.
Okay, thank you. Yeah, the public comments we had were very, very eloquent in describing how serious this condition can be, and that will factor into a subsequent vote that we'll be taking shortly too. Don, go ahead.
Yeah, Steve, I was able to actually learn a lot about this, and I think what strikes me is the phenotypic variation of the problem, and I think the question is answered differently, let's say, for example, for a hereditary population, or perhaps populations at risk like connective tissue disease like scleroderma, HIV, versus the idiopathic group, where I don't know, maybe Mark Simon knows, but, where that pops up. But it seems as though, at least from a trajectory standpoint, if there is knowledge of risk, and I think one of the public commenters made a point about this, then that would be a good lens to help sort out amongst the various phenotypes. I hope I'm making some sense there, but it seems as though that's a question that's been on my mind.
Yeah, I mean, we've talked about different subpopulations, I guess, based on etiology, and that's somewhat linked to risk. Of course, these votes are looking at the whole population as they would now kind of be considered for pricing, for coverage, that kind of thing. So we'll come back to some of these issues too, though, when we get down to the specifics of how insurance coverage will be kind of created. Why don't we go ahead and put up that voting question, though? This is the one of two on severity. So based on the acuity of need for the treatment of individual patients, based on their short-term risk of death or progression to permanent disability, would any effective treatment for PH receive anything from, as you can see, very low priority to very high priority? And when we get 13 responses, we'll show the results. Okay. All right, 7 very high and 6 high. All right, excellent. So the second question, that doesn't mean that one is right and one is wrong. It's that there are two sometimes different perspectives on what severity can mean. So in addition to the short-term risks, now we're talking about the magnitude of the lifetime impact on individual patients of the condition being treated. I can only imagine that we all have emblazoned in our minds the testimony of the patient experts who gave public comment. But we have Julia with us again, and Julia, you are also part of that group. Anything else you would like to add to this question before we take a vote?
I think the gals who presented during the public comments did a good job of explaining the various areas of life that are involved with this disease, from the physical, tangible, how do you get your toddler a sippy cup? Do you have enough strength to refill their drink? To working, self-esteem issues. Do I have value to my family? Am I just a drain on them? All the way to, do I have anything to contribute at all? Or there's just a wide range. And I think the ladies did a good job of discussing that gamut.
As do I. All right, why don't we ask the CEPAC to take a vote on that question then? Okay, again, this is going to be the relative priority for any effective treatment for PH based on the magnitude of the lifetime impact on individual patients of this condition, from very low to very high. Okay. Okay, this time we have 8 very high, 4 high, and 1 average. All right. Now we're going to skip to a slightly different aspect of thinking about what we're going to, in a sense, call benefits beyond health, even though they're linked to health. So here we are talking about sotatercept and the view of the CEPAC panel on its relative impact on patients known so far. What do we think the relative effects of sotatercept added to background therapy are on the following outcomes that are also part of our broader view of value. So the first one here is patients' ability to achieve their major life goals related to education, work, or family life. Again, the impact on health will be what, in a sense, leads to this, if you will, broader ability for patients to achieve their life goals. But sometimes we see treatments that are kind of very short-term treatments, but we want to make sure that we think about the arc of the impact on patients and their lives. Sometimes it depends on how old they are on average when, the treatment is administered, that kind of thing. But again, the testimony we heard earlier was so germane to this question. But I would, again, invite Julia or Katie to say anything else that you would want to emphasize about the impact of sotatercept, at least what we know so far, and how you see it could affect patients' ability to reach their life goals.
I'd like to wait on this one, if I may.
You
Dr.
certainly.
Simon mentioned earlier how many other PH drugs have come to market. Their 6-minute walk may have been an additional 12 meters or 15 meters, 20 meters, but that this was shown to be roughly 40, and how that seems like a small number. But in the day-to-day, what that equates to is actually pretty drastic. For the other medications that I've also been on through the years, the increase of 12 meters might mean that I can now make it through a convenience store to pick up milk and eggs for my family. An increase of 40 means that perhaps I can now walk through a zoo with my family while taking stops as I need to here and there. And so from daily quality of life, it is drastically different. And in terms of the ability to get off the couch, as some of the girls mentioned, and perhaps have a volunteer position or a part-time position in life, is drastically different at that 40-meter mark. And so what looks like just quantitative data is actually hugely impactful qualitatively for the patients.
Thank you very much. Katie or Mark, anything you'd like to add?
Yes, I'll add, I think it came through loud and clear in the public comments, but the public comments are time-wise such a small portion of our day. So I really just wanted to reflect the significant mental health burden that individuals living with pulmonary hypertension face, as well as, again, that young age of diagnosis that often impacts, we heard from several folks who were diagnosed after giving birth to their first children, but really impacts, every area of major life decision, including whether to start a family, what it looks like to try to date and engage in romantic relationships with a chronic debilitating illness, right? Like pulmonary hypertension really, on average, starts relatively young and impacts the full range of lived experience for people with chronic disease.
Thank you. Anybody on CEPAC have a question or a comment they'd like to make before we vote? Okay, let's go back to the voting question. So sotatercept and its ability to impact patients' ability to achieve their major life goals related to education, work, or family life, from major negative effect to major positive effect. Okay. 7 major positive, 6 minor positive. If I had to guess, my guess is that people who voted for minor positive were just thinking about the duration of effect that they might still have some uncertainty about. And so they might see this effect in the short term, but thinking about it over the arc of a patient's life, they might modulate their vote down to minor positive because of that question. But let me invite anybody who did vote for minor positive effect, if you had something else in mind that would describe your vote, just so folks can understand it. Thank you, Aaron.
I think I was looking at it as major life goals, education, work, or family life. I mean, certainly it sounds like it makes a significant difference on daily activities of life, but I was thinking like, will this make a big difference with education or with my ability to go work? And it didn't feel as if it was a major positive effect for those major life goals.
Okay, Stacy?
Like Aaron, I was thinking along the same lines, and especially of the patient's testimonials related to them needing to stop work at different times because of their disease, and thinking this might not change the trajectory of needing to stop work, but it certainly has many strong benefits for people. But I think it was considering that, like, the size of these life goals we're talking about, I'm hopeful future drugs fully change that trajectory for people, but this seems like a really strong but more minor improvement related to these particular outcomes.
Okay, thanks. And Heather?
Very much the same. I kind of waffled between 5 and 4, and I guess I struggled with the implications of quote unquote major and longitudinally what that looked like. So I kind of erred on the side of 4.
Okay, I think that's helpful for folks. Oh, we have Kurt. Go ahead.
Yeah, and for me, as we get more data, this could change. That we definitely see this, with quality of life data and so on. So that could change over time from my perspective.
Okay, thank you. Let's go to the next question, which is about the caregivers. And again, the public comments was eloquent on this point as well, family members. And so I would expand this to consider family members, even if you wouldn't technically consider them to be caregivers. We want to think about what is the impact of sotatercept on their quality of life or their ability to achieve major life goals related to their education, their work, or their family life. So again, I feel like we could just tee up the wonderful public comments we've already had. But Julia or Katie, would start with you again. Anything else you'd like to say about that?
I can speak to my personal experience with that.
Sure.
My husband through the years has had to turn down huge job offers because their insurance wasn't sufficient. And so my diagnosis has had a tremendous impact on his career. But since I am now functioning at the level that I am, he's had the ability to have the freedom to accept more recent job promotions, which involve tons of travel. This month, he's actually gone, I think it's 13 nights, where traveling for his career, where for a long time he needed to be homebound to take care of me, to make sure I was okay, to call 911 if necessary. So within our own family, it has freed him up for a lot of those goals that had been put on the shelf for a number of years as my caregiver.
Thank you. That's a great example. All right, why don't we go ahead and put up the voting question. So again, sotatercept's impact on caregivers' quality of life. I don't think I need to read it again to you all. You can see it. So please go ahead and vote. All right. 8 and 5. I'm guessing some of the same reasonings probably went into the division of the votes here. If anybody has a specifically different perspective that they want to introduce as far as behind their vote, Brad?
Yeah, I think this was I felt like on the previous question, there was data to support, the impact of the patients. The trial data on the caregivers, I think, is likely to happen, but we just didn't have as close a data to match the outcomes of this question.
We always encourage, in our interactions with industry, our own message has always been to please gather data when, it's lovely to have strong impressions and anecdotes. Those should be powerful as well in terms of people's thinking. But data is a good thing to have too. And so these clinical trials, to the extent they can capture that. I mean, Julia, you talked about the quality of life instrument. You probably spent how many minutes answering all the questions that you were being asked to? Lots of time, right? So probably wouldn't have hurt to have had one more question about the impact on, your family's quality of life in some way. Be interesting to see what that would look like. Okay, let us go ahead. Okay, this one is more about, again, an element of value that is sometimes very important, sometimes not important at all, but we tend to ask it either which way. So it's about sotatercept as a treatment option in the landscape of options for patients. What do we think about its ability to impact patients' ability to manage and sustain their treatment, given its complexity versus the currently available third line or fourth line treatments? Mark, again, do you mind just reminding everybody, when you think of currently available third line, fourth line treatments, we've heard about this, but what is their complexity for patients in terms of their ability to do them?
Yeah, sure. So the one that we've heard about the most probably is Selexipag. It's a oral medication twice daily, has some outcomes data, and I think I had pointed out the 6-minute walk data with it earlier, about 12 meters. So that's one. There are, I guess you could throw into sort of third line some of our inhaled therapies. They are at this point 4 times daily. There's a nebulized version and a dry powder inhaler version.
What percent of patients are on an IV in your experience?
Yeah, so I actually was just looking at some of our data on this. So I would say that we have roughly about 10%, I would say, out of our large patient population are on an infusion-based therapy. So and there's a number of reasons for that can make that vary regionally and in centers that include, as you can imagine, the ability of patients and families to be able to utilize those therapies safely, and that's going to vary a lot. So that would be the other set of I don't know if it's necessarily fair to call them third line, because depending on the illness of patients, we'll, as you've kind of heard from patients, we'll jump to use those first.
Right. So, okay, we've got a couple questions. I'll just note for the CEPAC again, this question is not meant to suggest that every single patient will find their treatment regimen made less complex or more complex. But we're seeking to understand whether there's an opportunity for at least a meaningful proportion of patients to have their treatment complexity become much better, much easier for them, so that they can do better with managing their adherence and their use of the treatments overall. Don, and then Kurt.
I'll let Kurt go first.
Okay. So this drug is given sub-Q every 3 weeks, which is good. It's a little odd, but it's good. But my understanding is this is given in a clinic setting, most likely. So for me, it makes voting on this a bit tricky.
Understood. And actually, that was going to be another thing we were going to cover in the policy roundtable, is whether patients will be administering this to themselves at home or whether they will be, traipsing into the doctor's office every 3 weeks.
A quick point to that, if I could, because I've had the same question and concern as a provider, right?
Sure.
Okay, this gets approved. Does that mean anyone I want to have on it's going to have to come into clinic every 3 weeks? My understanding is there was some attempt to review a home-based injection sort of approach by FDA. I don't know the status of that with FDA. I'm certainly keeping my fingers crossed, because I think it will be much more, I'll be able to use this with many more patients if it can be a home-based therapy.
So now I'm on Team Kurt, because I don't know whether we should be asking them to vote based on its use in the clinic, which could actually increase the complexity for some patients, or whether we should assume that there's a future in which it's used primarily or exclusively at home. ICER team, you've been spending a lot of time thinking about this kind of issue as part of what you've done. Any guidance that you would give us in terms of how you think the vote should be framed?
I guess I would suggest, given what we've heard, that even if at the beginning it's required to be in clinics, I think most people think that over time it will move to home.
That would be my gestalt too. And I actually think there are payer reasons that they would prefer to have it given at home as opposed to in a doctor's office. So there might be lots of incentives aligned in that direction. Let's try to be quick, but I want to go through people who might have questions about this or comments. Don, go ahead.
Yeah, it seems as though that would be, given the side effect profile, a good opportunity to make it easier to do sub-Q. But I just reminded myself that there were a significant number of patients whose overall therapies could actually be reduced. In other words, either another therapy in the double or triple categories could either be reduced or perhaps even eliminated. So that helps guide my thinking.
Yeah, thank you. Alan?
Can you hear me?
Yes.
Oh, great. Okay. My microphone's been tricky lately. I think I know the answer, so this is more for just reinforcing or correcting me if I'm wrong. We're supposed to think about this in the context not just of the individual treatment, but the regimen of therapy, right?
Correct.
So could the clinicians or maybe the patient experts speak to what is the continued background therapy that is associated with this particular therapy? So what else, there are other things you still need. So what does that look like?
Mark or Dave, actually, go ahead, David. I know we've talked through this too. It's a tricky framing question, but go ahead.
Yeah, so if it's going to reduce the complexity, it's going to do it because some patients who otherwise would have progressed to the point that they get to infusions or an inhaled therapy don't need it. And I think given what you're seeing in the trial, it's believable that that will happen in some people. It's not going to happen in everybody. And in the trial, there were people who were on infusions and stayed on infusions plus this therapy, and it's not going to decrease complexity in people who are already on a really complex regimen. So I think you would have to believe, and it doesn't seem like a huge leap to believe it, that there are people who starting this would be delayed at least in moving to infusion therapy or an inhaled prostacyclin or something like that.
I'll just say I think that's absolutely the best way to think about it. I would really urge caution against thinking about it as this medication could lead to being able to peel back other medications. That's always a really tricky thing clinically, particularly in this disease state. We've seen difficulties with that. Could we one day have data to that effect? Okay, that would be great, but I would caution against thinking about it that way right now.
Great. Thank you very much. That's really helpful commentary. Why don't we go ahead and put the voting question up again? So this is sotatercept and its effects on patients' ability to manage and sustain their treatment given the complexity of their regimen versus currently available third-line or fourth-line treatments. Okay. 10 minor positive, 2 no difference, and 1 minor negative. All right. It's quite reasonable. Let's move to the last of these voting questions in this section. So sotatercept as a treatment and its relative effects, would it have everything from a major negative effect to a major positive effect on society's goal of reducing health inequities? Grace, do you mind just reminding folks how the ICER research team came to think about this over time?
Yes. So, the population from registry data of people diagnosed with PH in terms of race and ethnicity doesn't appear to be substantially different than the U.S. population. So we didn't see, any particular racial ethnic population that might derive additional benefit. However, there are inequities in access. For example, patients who are older, who may have difficulty with some of the current treatments, managing some of the current treatments, who may live in rural areas, who may have access issues, and or people with limited social support, since some of these like infusion therapies require a lot of support. So those were the things that came up in our review of health inequities.
Okay. Anybody on CEPAC have a specific question or comment they'd like to make? Great.
Well, the obvious, and that is the price of this drug. And, it's just not clear how everyone would be able to afford this, how that is going to all play out. Is there going to be co-insurance, co-payments? What's going to happen to premiums? So I can't really think all that through in terms of inequity, but I can certainly imagine a scenario where it might not do very good things for equity.
I know it's hard because we don't have a price. The company has not named its price, and there's this placeholder price in our report that came from some analysts' projections. But to a certain extent, this question is meant to capture the possible benefits to address inequities. And so to a certain extent, since we don't know the price, if that is going to have a huge impact here, but we ought to think again about the relative prevalence of this condition in certain communities that might have had, a lot less equitable care over the years. There's some examples that could stand out very clearly in this. We ask this question for every topic, and sometimes it's really not that much of a major factor in our thinking about the value of this particular treatment. Reem, go ahead.
Well, in addition to what's been mentioned, I think also our uncertainty about if this is going to be given in an institution versus at home will have big impact on inequity. Depending also on where majority of the patients' insurance come from, are they do they all have these insurance, or do they get them through family members? And so I don't think it's a small issue. And I do have concerns about inequity because of all the above, especially again, that this is a disease that unfortunately disproportionately affect young women.
Okay. Don, go ahead.
Well, I just remembered to think about the fact that the initial trial was in, I believe, 8 different countries in 4 different continents in 43 different centers. So I don't have a perspective on, let's say, the South American healthcare delivery system to think through this. I imagine that everyone is dealing with the same question, but the magnitude of it may be much higher in other countries that are less economically advantaged. Just thinking. I don't know the details, but it just seems like that heterogeneity makes the lens wider.
Okay. Yeah. I would encourage you, for this question is already complicated as it is, I would frame it as the impact on the American scene. And for now, we would leave out the impact potentially on foreign countries. Let's go ahead and take a vote on this last benefit beyond health, or potential benefit beyond health. So this is sotatercept and its relative impact on society's goal of reducing health inequities, everything from major negative to major positive. And the answer is no difference 8, minor -4, major -1. I think we heard a lot of the rationales behind those votes in the comments that came out beforehand. Thank you very much. We're actually right on time to take a 10-minute break before we come back. We're not going to do the long-term value for money question. I think I may have already mentioned this. We do this when we do have a price. We don't think it's fair, if you will, or reasonable to take a vote unless we have a price. So we're going to pass on that question at this time. And that means we can take our break. We'll come back in 10 minutes to start our policy roundtable, which I think will be really a fun way to pick up on some of the issues that have already come up. And we'll be talking very concretely about where this treatment will fit in the landscape and how it's going to be covered by insurers, its pricing and other things. So we'll see everybody back at the top of the